Okay, I think we might get started. So welcome everybody. I'd like to begin by acknowledging country. I'd like to acknowledge the traditional owners of this land that we're meeting on today, this fabulous part of Melbourne, the Wurundjeri people, the Kulin Nation. I'd like to acknowledge their elders past and present, and of course any Indigenous researchers in the audience today. So my name's Rob Ramsey. I'm a lab researcher, and that's probably why I'm not wearing a jacket and tie, I suppose. So I'm the joint head of the GI cancer program here at Epidemic, and I'm also a professor in the clinical pathology department at the University of Melbourne. So what's the VCCC? Well, I have my own definition. I've been given one to speak about, but I always go off script. I cannot help myself. So I think of the VCCC, the Victorian Comprehensive Cancer Centre, as really a geographical as well as a virtual precinct. It brings together 10 partners across Melbourne, very broadly across the river, and all of the people that are interested in the treatment and management of cancer. And together, I think we form what's called a precinct of research and clinical excellence in the treatment of patients with cancer. This precinct parallels quite a few around the world, and of course we don't look within, we look without. We're trying to look after Victoria and all of our community, and also projecting out to Australia, but really we have a national and international focus. It's a great place to work and a great place to present today's invited speaker. I'd like to welcome Dr. Ahmad Aly. Dr. Aly is Melbourne-based Uupper GI and Bariatric surgeon. He's trained at the Austin Hospital in Melbourne, and he's completed specialist Uupper GI fellowships in Adelaide and the UK. Ahmed is currently the head of the Uupper GI surgery department, I suppose, at the Austin Hospital, and he's a clinical associate professor with the University of Melbourne. So we're sort of like alumni, I guess. Ahmed has performed over 3,000 specialist esophago-gastric procedures, and 3,000 is a large number, and as you can imagine, anybody who's done that number is going to be an expert and very skilled. I work with a lot of surgeons in this precinct, and those that have done a lot of the same procedure are the best, and they're the ones that you want to call upon. He's a regular contributor to national and international meetings, has had many presentations, and has quite a few peer-reviewed publications and book chapters. So he comes to us as a real expert, and I'm really fascinated by this. I did a bit of a search on him and the area before I agreed to be the MC today, and I think you'll find it very fascinating. And one of the things I did was I looked up the Australian Institute for Health and Welfare, which is really the peak body that assesses the health of Australians. And I was alarmed to see that 2 in 3 adults have waist circumferences, that is around here. I looked at my own BMI, and I'm not going to tell you what it is, but I'm a little bit embarrassed. And that circumference is a predictor of metabolic disease. 1 in 4 children, more alarmingly, are also at risk. So this is pretty important, but what does it mean to me? From my perspective, such are the circumstances of the consequences of that obesity that it impinges upon inflammation. And inflammation is a key factor in the way we think about cancer today. And in turn, that inflammation, if not managed, is a risk factor for diabetes and, of course, cancer. So today, Dr. Aly is going to talk about bariatric surgery. He's going to pose the question, can it be a cancer operation? As the links between obesity and cancer continue to emerge. And we've already been chatting, and I think we'll probably chat afterwards about potential collaboration. So please come to the podium and welcome.
Thank you, Rob, and thanks to the VCCC for the invitation. Thank you all for coming along as well. I can see the weather's perfect outside, so if I was you, I'd be out there rather than here listening to me. But since we're all together, let's talk a little bit about obesity, cancer and bariatric surgery. Standard disclosures, I am on medical faculty with Ethicon Australia for their education programs, and I receive honorariums for lectures now and again. But I do have another disclosure. You may well recognise this man. This is Waleed Ali. He's on the project. He's the anchor. His surname is spelt the same way as my surname. And so I know there's always a lot of speculation. I just want to make it clear. I'm going to disclose I'm not his brother. He's my brother. And he's actually not that impressive. I know you all get carried away with him. He gets makeup and suits. But he can't even take out a gallbladder, so I'm telling you. And then he just sits around and talks all day. I don't know what that's about. And I'm on TV too, so I don't know why he's on. Anyway, Rob's already alluded to this, and don't worry about the chip on my shoulder, it'll go. Obesity is a public health epidemic. In fact, it is probably the single most important health issue of our time. And some of these figures I've already gone through, but 68% of the adult Australians are now overweight or obese. 38% are obese, that is a BMI over 30. And when I started working in this area some 10, 12 years ago, that number was 27. So you can see how alarmingly it's increased. 12% are morbidly obese, that is their BMI is over 40. This is the really high risk group. And 20% of our children are now overweight, and this has major impacts not only on the individuals suffering obesity, but on all of us in our community. So it's now starting to dominate our health infrastructure and architecture, and it costs a lot of money. Because it does this, obesity affects virtually every system of the body in multiple ways. And if you look through those diseases and those impacts, you will see that they're basically all of the common ailments that are in our society, in our community. And obesity has either direct causative links or the ability to exacerbate these things. It has a profound impact on health and well-being. And it's now well established that there are at least 13 types of cancer that are strongly related to obesity. And this evidence comes from multiple large-scale epidemiological studies that are prospective in nature. So there's fairly strong evidence for these. And I won't go through every cancer, it's really just to illustrate that link. Obesity continues to increase in Australia and around the world. It is a modern phenomenon, it is an effect of our environment. One way I like to think about it is that genetics loads the gun and the environment pulls the trigger. So you need the genetic predisposition, but if you're in the right environment, obesity is almost inevitable. And here's what's really interesting is although we're all concerned about the increase in cancer, when you dissect it out, actually cancer incidence, non-obesity related cancer incidence is falling. Obesity related cancers are the ones that are on the increase, and they're responsible for the increase in cancer that we see. So how strong is the evidence? Well, this is a very detailed meta-analysis, and I won't go into a lot of detail, but different cancers have different strengths of association, but the evidence for them is very strong. In this area, you'll see esophageal cancer and uterine cancer. We'll talk a little bit about those later. And these ones, the association is smaller, but these are also often more frequent cancers, and it might be why the association appears to be smaller. But this does confer an attributable risk, or if you like, how many cancers could we prevent if we didn't have obesity? That's the sort of statement. And again, from the same research, you know, up to 30, even 40% of the highly associated cancers might be prevented if obesity didn't exist. This is sort of not new. Researchers and cancer specialists for a long time have recognised the link between diabetes, particularly type 2 diabetes, and cancer. And it's often been talked about in that way. But what's probably really becoming apparent is that the link is actually more to do with obesity and the metabolic syndrome, the metabolic derangement that obesity creates, of which type 2 diabetes is one of it. And there might be some subtle differences between the two, and some cancers more predisposed if you're diabetic and obese rather than just obese and so on. All of that hasn't really been teased out. But by and large, if you look, this is the obesity-related column. The more red it is, the stronger the association. This is type 2 diabetes. They kind of parallel pretty much. There are some contradictions. and that probably relates to the actual physiological state at the time, or perhaps the level of insulin, which is a growth factor. So there's various little subtleties like that, but by and large, that link with diabetes and cancer really relates back to obesity and cancer. And the relationships are complex. We haven't really sorted them all out yet. So for example, ovarian cancer is associated with obesity, but it seems to be teenage obesity that's critically important in that increased risk. In breast cancer, it's postmenopausal breast cancer that's associated with obesity, but the data about what's the critical time of exposure of that obesity is confusing. It's not clear. Right? Is it premenopausal? Is it postmenopausal? Is it at the time of diagnosis? All of those things are still cloudy. Premenopausal cancer doesn't seem to be associated in incidence with obesity, but it does seem to be associated with its aggressiveness if it does occur. Prostate cancer is an interesting one. Of course, prostate cancer is very common, and the association with obesity is not particularly strong. It's there, but it's not in that high category. And that's probably, as I said, due to the fact that it is actually a highly prevalent disease. But obesity does have a very strong association with prognosis in prostate cancer and survivorship. And in fact, and this is maybe a bit dramatic, but it's probably a nice way to think of it. In a recent meta-analysis on obesity and prostate cancer, they actually made the statement that weight loss is more effective than chemotherapy in preventing death. Okay, I don't know if that's quite true, but that's the way it was put, trying to make the emphasis on the link. So obesity is not only related to incidence of cancer, it's also related to cancer mortality. So now, this is not all obesity, this is only the beginning of obesity. You can see here the BMI of 30. So my point is not particularly effective, is it? But it's only about here. So this is the flat line, but you see it starts to increase after that BMI of 30, and they haven't shown you the higher levels of obesity on this graph. And the same for females, it's actually more dramatic for females. So cancer incidence and mortality in its relation to obesity is more strongly associated in female cancers than it is in male cancers. It is still there in male cancer. The problem is that males die of cardiovascular disease. In obesity, it's actually cardiovascular disease that really spikes up, and that's the cause of their mortality more often. And Rob alluded to this, not all obesity is the same, okay? So you can ditch the whole concept of BMI and just look at waist circumference, which is just another way of measuring it. You know, I won't get into how do you measure obesity, but this is now looking at waist circumference. And basically 1, 2, and 3 just means increasing waist circumference groups. They looked at it in groups. And so the bigger the waist circumference, the greater the risk of cancer mortality. So central obesity, central adiposity, fat within the abdomen is more dangerous than fat that's on the hips or the thighs when it comes to, well, actually, when it comes to everything, metabolic syndrome, but also cancer incidence, cancer risk, cancer mortality. All of those things relate more strongly to central obesity, the sort of apple shape rather than the pear shape. Does it really confer poorer survival, and if so, does it do it directly? Well, obesity has been associated in smaller studies, often retrospective type data, to be associated with advanced stage of disease and perhaps with more aggressive disease progression, increased local recurrence, and reduced survival. It's best studied in breast cancer, but there is increasing evidence for endometrial cancer, in particular pancreatic, prostate I mentioned. There's been a recent meta-analysis. And colorectal I'm going to come back to because there's some really interesting new data on colorectal cancer. So is it that cancer occurring in obese individuals is different? Is it more aggressive? And is that explaining the mortality that's associated with it? There's a little bit of evidence for that, but not much. And so anyone here who's a lab researcher, here's a good spot to get into if you're looking for some PhD topics. So, but there's some idea that if you know a cancer is arising in the, let's call it the obesity environment of the body, the physiology of obesity, that perhaps it is different oncogenetically to other cancers that aren't arising. It kind of makes sense. Cancers are a reflection of the environment that it's in, and there's some evidence in breast cancer that might be so, but it's far from definitively answered. So what is this relationship of obesity and this cancer mortality risk, this increased weight? Is it because it's more aggressive cancer? We can't say yet. Is it a different cancer? We don't know. Is it a direct effect of the obesity? Is there something the obesity is doing that makes these patients more likely to die from a cancer-related complication? Or is it complications from treatment? Is it simply that when you've got obesity, you're more likely to have heart disease, you're more likely to have diabetes, you're more likely to have other things that put your health at risk, make it harder for you to tolerate treatments, make your survivorship less? Maybe it's just an obesity effect rather than a cancer effect. It might be that it's more difficult to treat. Certainly surgery is harder in bigger patients. You don't get the same clearance of nodal disease, for example. Perhaps that's where it is. And of course, this is going to be different depending which cancer you're talking about. But these all remain uncertainties. What is clear is that whatever that mechanism is, there is an association of obesity and poor cancer survival compared to the normal weight group. There can be a few paradoxes. We already said, for example, that esophageal cancer is highly associated with obesity. It is more frequent, and I'm going to talk a little bit more about that. But there isn't really any data that suggests their mortality is any different. And in fact, some data suggests it might be better, because these are, of course, gut cancer, stomach, esophageal cancer. Cachexia is actually one of the biggest problems. And maybe if you start off with a bit more reserve, you're a bit more likely to survive. So you can get these sort of paradoxes. But outside of mortality, obesity, of course, affects quality of life anyway, and that's relevant to cancer survivors too. So the quality of their life after surviving cancer is also impacted upon by their obesity. And so thinking more holistically and globally, and that's the comprehensive cancer care services that we all want to work in, we're all trying to bear that in mind when you're dealing with those individuals about what other impacts are obesity having in their life that can affect their cancer survival. So why does this all happen? Rob's alluded to some of it, but we'll go into a little bit more detail. These are the principal mechanisms of these associations that have been put up. So we've already said uterine cancer, for example, and there's a lot of work on breast cancer. Female cancer and female cancer mortality and obesity is a real concern. And it's largely attributable to an increase in circulating estrogens. Keep it sort of simple and not dissect them down. But there are other mediators of inflammation that occur in obesity. Rob alluded to that. And a really important one is this insulin growth factor axis that occurs in metabolic syndrome. The interaction of insulin resistance occurring peripherally, the effect of that on the liver, and the generation of metabolic syndrome, and what that does to not only inflammation, but also direct growth factors. Because fat in obesity is not simply weight. This is an active metabolic tissue. It does stuff, it makes stuff, and particularly the fat of central obesity inside the abdomen, the visceral fat. It interacts with macrophages and it produces inflammatory cytokines. The fat itself makes inflammatory mediators and other mediators of angiogenesis and so on. It's the initiator of insulin resistance and metabolic syndrome. And it's responsible for increased circulating estrogen by processing steroid hormones peripherally into estrogen. And so that's what you see in a little more detail. The fat tissue itself makes leptin. There's a reduction in adiponectin, and that has angiogenic and mitogenic effects. There are a release of inflammatory cytokines from macrophages that are activated in this area of metabolic fat, producing inflammatory mediators, TNF-alpha, IL-1, IL-6, and so on, that promote injury and chronic inflammation, which I'm sure everyone here understands the role of inflammation, particularly chronic progressive inflammation, in the development and progression of cancer. There's the peripheral aromatization I mentioned already. And in insulin resistance, one of the first things that happens is you get hyperinsulinemia. Insulin itself is a growth factor, but associated with that, you get an increase in IGF-1, which is a very well-known growth factor and driver of proliferation and carcinogenesis. So the inflammatory pathways are activated by this interaction of this active metabolic fat. You get multiple mediators that we've mentioned that all enhance proliferation, angiogenesis, encourage metastasis in various models, and chemo resistance potentially. So they may make your treatments less effective. And this happens both systemically, released into the blood, endocrine system, as well as locally by a paracrine effect in the tissues where the cancer is growing, potentially. So insulin resistance, stimulated again by the peripheral fat and creating an effect. So insulin resistance causing hyperinsulinemia, there's increased lipolysis and increased fatty acid circulation. All of this has an effect on the liver to stimulate gluconeogenesis, and that creates an increase in IGF-1. It's in here somewhere, there it is. Okay, and the insulin, and these are growth factors. Just as an aside, we sort of mentioned prostate cancer and its relationship. There's been a number of studies that have shown fairly clear links between this hyperinsulinemic state and associated prostate cancer. It doesn't necessarily mean it's causative, but there's a very strong association between the two. We talked about peripheral aromatization, so the fat tissue processing steroid hormones and creating estrogen, and that being circulating and therefore potentially stimulating female cancers. But it also happens through metabolic syndrome. So here you have, because of the effects on the liver, a reduction in steroid hormone binding globulin, and that leads to an increase in the bioavailable estrogen, which has direct effects on IGF-1 and on the uterus, and therefore driving uterine cancer. So I'm going to put it to you that cancer is actually a metabolic disease. We've always thought about it in terms of oncogenes and you know, injury and so on. Well, it's being driven by metabolic syndrome here. Well, at least the obesity-related cancers anyway. So uterine is very strongly associated, and esophageal is very strongly associated. We've talked about the circulating estrogens and how that might drive it. We'll talk about inflammation. We're going to pause for a moment on esophageal cancer, because after all, I'm an upper GI surgeon and I deal with esophageal cancer, so I have a bit of a bias. The thing about esophageal cancer, although it's very highly associated here, it is still a very low incidence cancer overall. So demonstrating an impact of weight loss, for example, on esophageal cancer is actually quite difficult, because it's a low incidence cancer. But basically what happens in esophageal cancer is gastroesophageal reflux, so acid content from the stomach, perhaps bile, other things, refluxing into the esophagus create injury, that's esophagitis. And you get from there ongoing progressive inflammation from the ongoing injury leading to metaplasia, so Barrett's esophagus, which then undergoes further injury, again inflammation driving that, creating dysplasia and ultimately leading to esophageal cancer. And that's the pathway of adenocarcinoma of the esophagus. Well, obese patients suffer more reflux. They get more reflux symptoms. They also get greater acid exposure. So it's not just symptoms, it's also physical, actual reflux is exacerbated by obesity. So obesity is directly related to reflux, and we already showed that reflux is the main stimulant of esophageal cancer. Obesity is very clearly associated with Barrett's metaplasia. There's at least a doubling of risk if you're obese with reflux. But on top of all of that, obesity is still an independent risk factor for adenocarcinoma. So if you do a multivariate analysis and pull it all out, you'll find that obesity itself confers a risk, independent of reflux or Barrett's or anything else. And in fact, the effect is synergistic. So when you look at reflux alone, it doubles the risk of esophageal cancer. Sorry, it increases the risk of esophageal cancer 5-fold. Obesity alone as an independent factor, twice, but you put them together, well, now you've got dynamite. So they act synergistically. They're not simply additive. And that's the kind of pathway, I guess, that we're putting up. You've got metabolic obesity driving inflammation and Barrett's. This is a synergistic effect. You've got the mechanical effects of obesity driving reflux. You've got independent effects of obesity through inflammatory cytokines, perhaps IGF even with the metabolic syndrome, and all of that is acting synergistically to produce an increased risk of cancer. So obesity increases cancer risk, it increases cancer death. The obesity effects on cancer are mediated metabolically. We've demonstrated those things. Does weight loss work? Does it make a difference? Well, in theory, it really should. If you reduce that active metabolic fat that's driving everything, then you should see a reduction in insulin resistance. You should see a reduction in inflammation. And this has been repeatedly demonstrated. This happens. Whether that translates to cancer reduction is another question, but this happens. If you get effective weight loss, you can reverse metabolic syndrome. That's clear. With weight loss, we get reduction in circulating estrogens, we get an increase in the binding proteins, the inflammatory mediators go away, we definitely get rid of hyperinsulinemia, we can put diabetes into remission. The studies aren't so clear on IGF-1, I've never really understood why, but that's what the data shows. So what happens in cancer patients? Well, this is really hard. If you look at just weight loss, it's difficult because, of course, cancer induces weight loss, and you don't know if the weight loss is intentional or unintentional. The data is really heterogeneous. It's very difficult in that type of study to tease things out. But even despite that, when they put it together, the estimate is about half of the studies demonstrate there seems to be a decreased risk of cancer in at least half of those studies, particularly, again, in those female cancers, the breast cancers and the uterine cancers. So if you look at cohort studies, of which there aren't many, this is 3 of them, where there is intentional weight loss, intentional program, there does seem to be some cancer reduction risk, although I've got to admit the data is a little bit hard to understand. So these are very large populations. 19% of this population undergoing intentional weight loss, okay? The outcome is cancer mortality, and there's an association of this group having a reduced risk of cancer mortality with their weight loss, okay? This is in women. This is the same study looking at the men. They didn't see a difference in mortality. So this seems to be particularly effective for the hormone-responsive cancers. Okay. In this study, 17% of the population achieved weight loss that was intentional, and again, there was a reduction, and this again is a study in women. So yes, weight loss, intentional weight loss, does seem to confer, at least in hormone-responsive female cancer, a degree of protection against cancer development. We might be able to prevent some cancer. Here are some randomized trials that tried to look at dietary interventions. I think this is I personally think it's less useful data because there's probably a whole lot of other things going on here. So in fact, I was having a chat with Rob earlier about it's not just how much you eat, it's also what you eat and what the effect of those nutritional things are and what that does to the body and how that all interacts with insulin resistance and metabolic syndrome and so on. So it might be a weight loss effect that's produced this. It might also be a dietary effect. We don't really know. Can't be sure. So non-surgical weight loss, trying to study non-surgical weight loss and cancer risk and cancer mortality is difficult. It's difficult to interpret the data. In general, you only get modest weight loss anyway. It's very difficult to sustain. That's the whole problem of obesity and weight loss. And so it becomes hard to draw firm conclusions. What if we studied surgical weight loss? Is that better? What's the difference between surgical weight loss and non-surgical weight loss? Well, firstly, the magnitude of weight loss, all right? So in non-surgical weight loss, we're hoping for maybe 5 to 10% of total body weight. In surgical weight loss, we're kind of disappointed if we don't get 30% of total body weight loss, okay? But most importantly, that weight loss is sustained, at least in the medium to long term, 5 to 10 years. You get sustained weight loss rather than a yo-yoing of dieting and dietary interventions. And as I'll detail, there are metabolic effects of surgery beyond weight loss that maybe are also having an effect here on potentially on cancer prevention. So it is a different question. It's not just looking at weight loss. Why is it different? Well, it's a bit complicated, but essentially the body defends weight. Okay, it has a set point that it tries to keep the body at, and it regulates appetite very, very, very tightly. Right? It measures calories really well, and it will regulate things to get the weight back to that set point, which is why it's so difficult to lose weight in a sustained way. So the appetite in the body is controlled. I mean, it's a very complex thing. I'm only going to address a couple of elements in the appetite, but basically the appetite center of the brain is always on. The natural state of the body is to be hungry, and almost every other signal, in this case we're looking at signals from the fat and from the gut, almost all the other signals inhibit appetite. That's how appetite's regulated. Ghrelin, which is a hormone produced in the stomach, is one of the few hormones that actually stimulates appetite. Okay? And so when you look at obese patients and lean patients, you see differences in the levels of these hormones. So this is looking at ghrelin. Remember, ghrelin was the hormone that stimulated hunger. This is baseline ghrelin in a severely obese patient. It's high, and in the lean patient before they eat, it's high. But look at what happens to the lean patient when they eat. Ghrelin falls. So hunger disappears. But in the obese patient, ghrelin didn't change. In fact, it went up after they ate. So when patients suffering obesity tell you, I eat and I still feel hungry, they're not lying, and they're not making it up, and they're not lazy, and they're not lacking discipline. It's their hormones that are doing it. This is PYY. PYY is produced in the small bowel. PYY inhibits appetite. Okay? So again, let's look at our lean patient. There's their lean circulating level of PYY. So their hunger is suppressed, let's call it at 45. I'm just making it up, it's just there. Hunger suppression is at a level of 45, but look at our obese patient. Their basal rate level of PYY is already down here. So they're already starting hungry. When you eat a lean person, their PYY jumps in response to that to suppress the hunger. And then as they finish the meal and they're waiting for a while, it starts to fall to induce hunger again. Look at our obese patient. They don't get that. They just don't get that same spike. So there are physiological drivers that maintain a hungry state in obesity. And the problem is, as you lose weight, the worse it gets. Everything shifts towards making you even more hungry. And those hormone adaptations that do that persist in the long term. This is work from Melbourne University. In other words, obese patients are already physiologically hungry. The response of their body to weight loss is to stimulate appetite and to inhibit the sense of fullness. It drives eating behaviour in order to return the weight back to the set point. The greater the obesity, the greater the effect. And so what happens in almost every study that's looked at non-surgical weight loss is, yes, you can induce weight loss, but over time you'll get weight regain. And at best, about 15 to 20% of people will maintain about 5 to 10% body weight loss. But everyone else will regain and usually add a bit. That's the difficulty. What surgery does is it regulates this mechanism. It actually returns all those hormones back to where they belong to some extent. You get a hormone shift that reduces hunger and enhances the sense of fullness. So this is pre and post surgery, gastric bypass surgery, looking at PYY. Remember that hormone that suppresses appetite. Here is the patient before surgery. PYY is very low. There's virtually no response to eating. Here is the patient almost immediately after surgery. The red is 6 weeks after surgery. Already the PYY basal level is higher and they get this restoration of the curve back towards normal. So their hunger levels drop. They are now able to eat a smaller amount of food, not get hungry and lose weight. And that's why surgery produces more sustained weight loss. So we get significant weight loss without generating hunger. You get resettling of that set point at a new level, and you get more sustained weight loss. And with that, you get reversal and improvement of all those comorbidities we highlighted at the start, because you get a complete shift of that metabolic syndrome axis. But beyond weight loss, these surgeries have direct effects on metabolism. And diabetes is the clearest example of that. So here's another hormone, GLP-1. It's a bit like PYY, it suppresses appetite. And again, in the obese patient, it's flatlining pre-surgery, but it returns to normal after surgery. Here's what it does to insulin. And these are immediate effects, right? So preoperatively, here is the insulin profile of our obese patient. High levels of insulin maintained after eating. Virtually immediately after surgery, because of the effect of GLP-1, insulin smooths out to a much more normal profile. Insulin levels drop. And similarly, glucose does the same thing. Here's our glucose, postprandial glucose. and here it is after surgery. This is an immediate effect. This is not dependent on weight loss. Weight loss affects insulin resistance, but this is affecting insulin secretion. So we get improvement of diabetes directly, even without weight loss. This is a direct metabolic effect, and there are others. Right? So hunger isn't the only reason we eat. We eat for pleasure, we eat because we're emotional, we eat all sorts of things. Yeah? There's food reward pathways. So this is the hidden assassin. I sort of, I get pleasure from eating, so I'll keep eating. Well, guess what? We might think that people choose high energy foods because they just do. And it is true that obesity is associated with food reward systems in the brain, a little bit like food addiction. You get dopamine hit for eating certain types of food. But surgery seems to change it. And I cannot tell you what the mediator is, nobody knows, but this is a regularly observed phenomenon. Take patients before a bypass and you show them flashcards of food. It doesn't matter, it can be low energy or high energy. And on functional MRI, their brain goes nuts. They're very excited. You do it after surgery and you show them flashcards of high energy foods and the brain doesn't do very much. You get remapping of those reward pathways in the brain. And it drives people away from fat and sugar. Their food preference, not just taste, their food preference changes. And it's not because they're motivated, this is an immediate physiological response. And it doesn't happen in everyone. It's biologically dependent. It's just like when you give a tablet for blood pressure, it doesn't always work. Right? It depends on the person's biology. And we have no idea what mediates this, right? But it happens. So how much of our behavior is actually physiologically determined? There's a question. We also see increased metabolic rate. We get changes in adaptive thermogenesis. I haven't put it on here, but we get changes in the microbiome, and maybe that drives everything. So having a chat outside about that earlier. You get direct anti-inflammatory effects. It's been well studied in rheumatoid arthritis, where you get in 80% anti-inflammatory remission that is disproportionate to the weight loss. So there's a direct metabolic anti-inflammatory effect of these surgeries, and fatty acid changes, and probably lots of others that we haven't studied yet. But not all surgeries are the same in this regard. So I'm not going to do a whole surgical lecture, but gastric banding doesn't have any hormonal effect. It's purely a mechanical device to restrict food and lose weight. And losing that fat will have an effect on metabolic syndrome, but it's not a direct effect. It's all secondary to weight loss. Whereas these resectional procedures tend to have these metabolic effects that I'm talking about. And as we go from this one, sleeve gastrectomy, we move this way, we get an increasing metabolic effect. So not all surgeries are equal. So just sort of bear that in mind. But what I'm getting at here is not only is weight loss potentially anti-neoplastic, but there are probably direct metabolic effects of these operations that are also anti-neoplastic. The anti-inflammatory one being one of those. This is the Swedish obese subject study. It's very famous because it's very long running, very well maintained population level epidemiological study in Sweden, where they're really good at that sort of thing. And this is looking at obese patients that have either not had surgery or obese patients that have had surgery. It's actually quite old data. It's now out to about 18 years now, I think. And so some of these operations we don't use anymore. We have more effective ones, but nonetheless, we still see maintenance of weight loss at 15 years that's significantly better than the non-operated group. But this is what it tells us about cancer incidence. Okay, they looked at their 16-year data, and in women there was a significant reduction in female cancer incidence. They didn't see the same thing in the male cancers, a little bit similar to what we saw before. And again, it might be an incidence issue, but profound effects of surgical weight loss on cancer incidence and on cancer mortality. So they demonstrated a 38% reduction in cancer mortality, again, predominantly in the females. There's another study, large study of, it's a retrospective cohort study, so it's associated with all those problems. And in this operation, in this study, mostly it was gastric bypass, which is quite a strongly metabolic operation. And they saw a major difference in weight loss and a reduction in cancer incidence, again, for the females, but not seen for the males. But mortality overall was significantly different. So in the Swedish study, they showed 38–40%. Here, they're estimating up to 60%. Another relatively large, this database sort of study, Again, good weight loss in the surgical group. They didn't actually measure any weight loss in the controls, but you can take it that basically obesity without surgical treatment, they're not going to have significant weight loss. And they saw a significant reduction in breast cancer and overall a lower incidence in the surgical group, very dramatic lower incidence, but they didn't gender stratify, so we can't say anything on that there. What's interesting about all these 3 studies is the relative period of time that was studied was relatively short. So they seem to be inducing, so the latency between surgery and then measuring the risk reduction was relatively short. So it seems like intervening will produce an effect on cancer incidence in a relatively short time. So that suggests to me, I'm happy to chat to the lab people, that there's something about the endocrine and local milieu that is changing the way the oncogenes are being transcripted. Here's uterine cancer meta-analysis just showing after bariatric surgery, a reduction in the risk of incidence of surgery. You can see everything to the left of the line is good. Okay. So again, dramatic, essentially prevention of uterine cancer after bariatric surgery. And in fact, endometrial cancer now is actually one of the urgent indications for bariatric surgery. So if you're endometrial cancer in an obese patient, we're increasingly receiving referrals from our gynecologists for urgent intervention because they understand that the risk of recurrence and cancer death is significantly affected by bariatric surgery. This is a really interesting study. It only just came out. I think it's probably one of the most informative studies we have at the moment on the effect of bariatric surgery. It's from the UK. It's about 8,500 patients in each arm that are exactly matched. It's a cohort matching study. And I've tried to summarise, there's a lot of data in it, I've tried to summarise it sort of. And the reason I like it is because it distinguishes the different operations as well. And so you've got the hormone responsive cancers. Here's breast, uterine and prostate. They saw a difference in mortality. Remember I said incidence didn't seem to change much, but mortality did. So these are the hormone responsive cancers, breast, uterine and prostate. And overall, the odds ratio was significantly lower in that group. But it was different with different surgeries. Remember I said some surgeries have a greater metabolic effect? Now you can argue, well, maybe they also had more weight loss, and that's probably true when you're talking about band and sleeve, and band compared to sleeve and bypass. But actually the weight loss between sleeve and bypass is very similar. So I think this represents a metabolic effect of the operation itself, most likely. Okay. And there was a reduction in esophageal cancer, but again, the numbers are small, so it didn't reach statistical significance. And it was looking at mortality, not incidence. So I think it's a more difficult question to answer. But bypass was more effective. So does that mean that bypass has a greater effect because it has a greater metabolic effect? Is this a direct metabolic consequence of surgery, quite independent of weight loss? I think it probably does point to that. Maybe there are other mechanisms at play because the microbiome changes in these operations, particularly with gastric bypass. And maybe that's actually the mediator. Maybe that's where we need to be focusing. But here's a concern that this study raised. So we've known for a long time that colorectal cancer is associated with obesity relatively weakly. It's sort of, it's an odds ratio, I think about 1.3, something like that, okay? This is looking at survival. So here's our hormone responsive cancers, okay? Control group don't do as well as the surgical group. Surgical group survive better. But here's colorectal cancer. Our control group are doing better than our surgical group. In gastric bypass. They only saw it in gastric bypass. They didn't see it for sleeve and band. So maybe gastric bypass increases the risk of colorectal cancer. That's what this, and it's the first study that's raised this. I think there's probably a case there, and maybe it's the microbiome. Okay. Here's a study that really confused me, but I've included it because there's 18,000 surgical patients, 60% of them were gastric bypass, and they did see an overall reduction in cancer risk. And that was associated with weight loss when they did the multivariate analysis. And they didn't believe that bariatric surgery came out in itself as an independent predictor of that cancer reduction, which is kind of interesting because it goes against everything I just said. But it is a funny sort of result because they also concluded that weight loss did not reduce the risk for obesity-related cancers. I'm not quite sure how they got to that, but that's one of their conclusions, at least as an independent factor. But surgery did. So if anything, they're kind of suggesting that obesity-related cancers get better after bariatric surgery because of the surgery and not because of the weight loss. I'm not sure I buy that completely. But anyway, I've put it in there just to confuse us all at the end of the day. So in summary, obesity is on the increase and obesity-related cancers are coming along for the ride. Patients with morbid obesity do have worse cancer outcomes, whatever that mechanism is, but they do have worse cancer outcomes. And we need to think about our patients that are suffering obesity and cancer in that light. The mechanisms of that, I think, are probably consistent with the metabolic mayhem that goes along with obesity. And I suspect that bariatric surgery, particularly the more effective metabolic ones, will have direct metabolic effects on cancer incidence and cancer survival. The data's not there yet, but I just think that that's likely just based on what we've seen so far. And so, all you researchers out there, get cracking because it's a good area to research. Bariatric and metabolic surgery, I think, now has to be considered in the management of pathways of cancer care. And maybe we need to start thinking about that in terms of the VCCC and studying these things together. Or maybe we should just change our environment. Thank you.
Okay, we're going to quiz you. This presentation is open for questions from the audience. Please.
That was a great presentation. My question is, as a cause of obesity, does it make a difference when there is a genetic or there is a lifestyle as a causative of this? And the secondly, which I got from your talk, there is not much difference between appetite and the hunger. But always we believe there is a difference between the hunger and appetite. And the thirdly, as you mentioned, there is no very clear mediating why it's sustainable after the surgical reduction. But isn't that the fact, if you go through the lap band or bariatric, or because you are going through the traumatic process, and of course spending lots of money, you have more commitment, and there is some automatic force in your body. You are not able to eat as much as you used to. And as a conclusion, then comes to the cancer these days. Do you believe the recommendation or prescription by clinician prescribing the exercise, it does have a huge impact on curing or as a remedy for the cancer? Why still there is no such a thing as a recommendation by the authorities?
Okay.
Only 3 questions, you'll be right.
Start with the first one again. Just remind me again. What was your first question?
The genetic
The
and
genetic
the
thing, yeah.
lifestyle.
Yeah, okay. So, firstly, it's virtually impossible to tease out in any one person. You can't say, oh, it's lifestyle that's caused your problem or it's genetics that's caused your problem. You can't do that with one individual. In fact, it's always a combination of both, okay? And the genetic basis of obesity is very well established. It's not single genes, this is multiple genes, but the concept of genetic familial obesity is very well established and very clear. Twin studies are one of the most impressive sources of that, okay? Where you have identical twins raised in different environments and their weight virtually tracks exactly the same, okay? Their weight resembles each other far more strongly than the weight of the family and environment in which they grew up in, okay? So the genetic, and we're talking about obesity here, we're not talking about people that are 3 or 4 kilos overweight. It's a different, we're talking about something else, okay? So the genetic basis of obesity is very clear. What we haven't isolated, apart from some very rare disorders, is what are all the genes responsible? That's very complicated. There are actually some mappings now that suggest there are different types of obesity, but the genetic basis is clear. How it is mediated, well, there's still a lot of discussion. The appetite stuff, the appetite regulation stuff that I showed you is one mechanism that is very well established. These hormonal differences and hormonal changes before surgery and after surgery have been demonstrated repeatedly, not only in experimental models with rats, but also in many human studies. So I think that the hormonal changes, that's real, that happens. Is that the only mechanism by which it mediates sustained weight loss? Probably not. And there's a number of things that have been put up, which is why I said get into the research, have a look at it. Okay, but it is definitely a physiological effect. It's not simply because, oh, now I paid money and so now I'm going to be committed. Because you know what? All those dietary programs out there, they actually cost a lot more than my surgery. Most patients, by the time they get to me, have spent at least 4 or 5 times the amount of money on weight loss programs than they're going to pay for surgery. It's not the money. It's not about motivation. In fact, that's one of our difficulties. We try to guess who's going to do well with surgery and who isn't. And there's this, you know, we look at motivation, and we're always concerned about the patient that doesn't seem to have the right motivation, the right headspace or whatever. Guess what? They often do really well. Biology is very powerful. And when you manipulate the biology, as this happens here with surgery, you get very powerful effects. You don't always get them in predictable ways. There are still, I've got patients where you operate on them and they don't lose the weight that we expect, and we cannot explain why. We don't know. There are some studies that show that those patients don't get the hormone change that we expected, as one example of why it might happen. So I've got no doubt this is driven by biology. Motivation, lifestyle, all those things, yes, they're important. They all play a role, but central to this is biology.
Perhaps I can get you to speak very quickly about exercise and how you think all that fits together.
Okay, so I'm not an expert on exercise, but losing weight with exercise alone is very difficult, by and large. There are some individuals, for whatever reason, their physiology responds to it really well. Right? In fact, for them, weight loss is highly critical on exercise. But in the main, exercise doesn't help you lose weight because it drives appetite anyway, and then you eat.
What is it preventing of the cancer?
Yeah, I haven't.
Elements of life.
Sure, I haven't looked at that specifically, but we all know there are beneficial effects of exercise beyond weight loss. There's stimulation of the immune system. We know it reduces insulin resistance and it improves glucose control, even if weight loss doesn't occur. So there's definite positive effects of exercise, no question. Does it prevent cancer? I don't know. I haven't looked at that.
Maybe Joe? Oh, okay, sorry. You've got the microphone, so you're the boss.
I'm in charge for a second. Thank you, wonderful synthesis of the evidence. I've got an anecdote and a double-barrel question, I think. And the anecdote comes from the late 90s in my first years as a dietitian and giving dietary counselling in the outer and inner eastern suburbs of Melbourne to people who had stomach stapling at that time. And the motivation largely from the patients tended to be around appearance and not being able to run around after their kids in the back garden, bit of syndrome X, but different drivers from clinicians as they work with patients. So part of my question is how much awareness is there in patients about the preventative effects for other morbid conditions, including cancer? And secondly, are we at the stage where bariatric surgery should be used as a targeted cancer prevention strategy?
Second part first, no, we're not at that stage, I don't think, although in practice, it's certainly being used preventatively in the sense of someone who's actually had cancer. So we see referrals from breast cancer specialists and clinicians and uterine cancer specialists to say, this patient has had cancer, also has obesity, we're concerned about their risk of recurrence in future and so on. Because that data is pretty clear and I think that makes sense. There's some sense in that. But could we really start a bariatric clinic in the V.C.C. as a preventative thing? No, probably not. We don't have quite that data. I'm happy to have a go if you like. I'm going to answer your other part with an anecdote. So one of my early patients was a young male who had quite significant diabetes, had pre-dialysis nephropathy almost, and a host of other metabolic issues. And we did a bypass and he had an excellent response. So his diabetes went into remission. He came off all his medications. His renal function returned to near normal. His hypertension went away, came off all of his medications. And he came in, and I think it was at about 2 years post-op, and I was looking at this, hardly able to believe it myself. I went, wow, look at this, Theo. Look, you're off all your diabetes, you're on this and that. And he goes, oh, yeah, I know, but look at this, size 10 pants. So there's no doubt our goals and patient goals, they're different. And whether they do know or they don't know, they know the health effects. And very often they think that's the answer you want to hear. Because the first question I ask any patient is, why do you want to lose weight? Because it is about expectation setting and goal setting and looking at all of that. And you say, why do you want to lose weight? And you can tell there are some that have the prepared answer because they think that's going to get them surgery, you know. And then there are those that are just really honest. And there's no doubt appearance, self-esteem, self-confidence, a sense of self is a major driver. The kids one's a really big one. Often it's when they realise they can't run around with their kids and they can't go swimming with their kids and they can't do all of that. So there's no doubt that for patients, they are much more frequent and common and powerful drivers than the health issues or the potential risk of cancer. They like that's going to happen too, but the thing that often has driven them or brought them there are these other things that we might dismiss, but are actually part of well-being and quality of life, and may well contribute to health preventative things later when they feel better about themselves and better about their health, and they become more motivated after that. So I think it's all a compounding effect, and trying to tease them all out and be precise about it, I don't think is, in practical terms, all that helpful. If they've got a chance to benefit and they're very clear in their understanding of what's involved, then I think it's reasonable to consider it.
Okay, I think we'll make your question the last one, Jo.
Yes, thank you. I was wondering about if you could expand on the gastric bypass for the colorectal cancer, where you said it's a worsening effect. And if there was a difference between, or if it's even looked at with the lean obesity versus the severe obesity.
That study's the first one that's really shown that association so strongly and so clearly, and dissected it out for the different procedures. Before that, most of the studies were a bit mixed. They all seem to show a reduction in colorectal cancer incidence. And there are some studies that showed, in fact, not lower incidence. They showed lower advanced cancer and better survival. Whereas this study is actually showing worsened survival, probably through incidence. So it's conflicting data. But I just think the rigour of this study is hard to question. I think this is a really good study. So it's the first time it's been raised with that strength. So I can't really answer your question, you know, beyond that. The fact that it's occurring in bypass, they saw it in bypass and not sleeve. If we take that as being true, the metabolic mechanisms of both of those operations are fairly similar. If you look at appetite mediators, they're fairly similar. Bypass is a bit more powerful, and bypass possibly has it certainly has a greater anti-diabetic effect, and it has a greater anti-inflammatory effect. So you would expect it to have a greater anti-neoplastic effect, but clearly in the colorectal sphere that doesn't seem to be the case. Which brings me back to the question, and it's a complete hypothesis, I'm just throwing it out there. Is there something going on with the microbiome? Because I can tell you the microbiome after sleeve and bypass are different. Okay. Maybe that's the source of it. I mean, I don't know. It's a really interesting observation, and it's the first time that it's been documented in as rigorous a study, and it's made us pause and step back and say, okay, wait a minute, maybe we need to look at what the patient's risk of colorectal cancer is overall and to work out whether bypass is appropriate. Again, maybe it's not enough to do that, but we should be thinking about it.
Okay, I think we should bring to a close. I think all of you have got lots of, as they say, food for thought, and it's been a really fascinating presentation. I've certainly learned a lot. And I'd like to give you a gift on behalf of the VCCC, and would you join with me in thanking our speaker today?